Hello. I don't know why it starts out recording right away. I think we might need to change that in the settings.
Yeah, well, I think
Probably.
once the host joins, it's automatic.
Okay, I don't know if you could stop recording now so we could restart it when we
I,
stop.
I paused it.
Okay.
Is that okay?
I don't know how the video is if you pause it, I think, right? I don't know.
It makes two files. One
Okay,
of them
good.
is,
Perfect.
a short one, and the other one is a long one.
That works.
So, yeah, people are joining. I'll admit them.
Mhm.
Hi,
Hi, Maria. How are you?
I'm doing good. How are you guys doing?
Good. We're good.
Am I ready
Thank
to
you.
share my screen?
Give us a second. I think we'll just wait for more people to.
Hmm.
Okay, sounds good.
Yeah, just give it maybe a few more minutes for people to join. This is typically, Maria, a smaller group. uh, Different group, but a smaller group. And you might see there might be some care coordinators that join as well. It
Okay.
really depends kind of on the day. There's no
Okay.
CEH for this one, right? So this is really designed for providers. There's no CEH attached to it.
Okay.
But we still have care coordinators pop in and
Hmm.
listen in.
Okay. And I sent you the PowerPoint so
Yep.
you can share it with them if they want to go back and
Yeah,
look at it. Yeah.
that
Mhm.
sounds great. I
I'll leave my contact info in the chat when I'm done. So if they want to reach out to me directly, they have my contact info if they have questions.
sounds good.
Good. We're three after. I think we could get
Yeah,
started.
we can get
And
started.
we're going to record it, so give us a second.
Okay.
Hit record.
Okay.
Mhm.
Hi, everybody. Welcome to our provider monthly info share on this wonderful day in May and May 20th. And today we have uh, about 12 people in attendance, and we have our guest presenter from staff from Ancora who are here to share some wonderful information with us. Um, who we are is SDS training and care coordinator liaison. Kara, that's me. Kat, care coordinator liaison, and Damon with training. And we have folks representing our residential services community and a couple other service provider types in with us here. Typically, we have a mixture of folks, some care coordinators, some people doing other community-based services, all serving people through home and community-based waiver. And we'd love to learn more about Ancora.
Awesome. Well, thank you. So I'm Maria. I'm a patient care navigator here at Ancora. And then I have Ruben here. He is a registered nurse. He's been working for hospice for us for about 4 or 5 years. Right. Yeah. So I wanted him to come because there's going to be providers on here. So if they have any more in-depth clinical questions, he's a great person to help us answer those. Nice to meet you all. It's Ruben. So I'm going to try to share my screen. Let's see here. Got the right one. Yeah. Can you guys see it?
Yes, we're good.
Okay. I wanted to do the slideshow. Let me see. Okay. So We're Ancora Home Health and Hospice. We do in-home care for patients that are homebound. So we do both home health and hospice. So what we really want to educate providers about is the hospice benefit, because I feel like in Alaska that um, the benefit isn't getting utilized enough. And sometimes patients wait too long to find out about all of their options. So that's our main focus is just educating on the hospice benefit. So hospice offers compassionate care with the focus on quality of life. So comfort measures, a lot of times keeping patients at home when they're most comfortable is what we like to focus on. So, who is eligible for hospice? I know some of you might have heard me talk about this already once before, but typically it's a patient that is terminally ill. So, if they get a diagnosis that's 6 months or less, that typically will qualify a patient for hospice. So, we're focused on comfort care rather than a cure. So, if they're no longer looking to seek any type of curative treatment, that's typically when we feel like they're eligible and ready. And I know I have an hour, so I'll try not to go too fast. So Ruben is part of the hospice team. He's one of our administrators, and I know he still does visits. So once somebody gets put on hospice, typically it consists of having a whole hospice team. So with that being said, once a provider sends us a referral, Ancora takes over as their primary care provider. So when they get put on our service, the patient's care goes under our medical direction. And then I know if you want to add, if you're a provider, you can follow the patient. That is an option for them if that is something that you want, if they wanted to do.
That is correct. If they want to maintain their primary care physician to oversee our plan of care, that is totally fine. It's always up to our patient's discretion. The only thing is that the primary care would have to be available for our interdisciplinary groups and also be willing to sign off on plans of cares for that patient. But definitely they can remain with primary care physician.
Yeah, so they just have to be available to us. And a lot of times, to be perfectly honest, most providers are saying thank you, but no, that's okay. You guys can take over from us from now. And then I try to follow up and let the provider know when the patient has passed away. We do a lot of lunches with providers and clinics around town. And I think the little bit of feedback that I've always gotten back from the main provider is that they're like, once we refer to hospice, we kind of like don't know what happens, they kind of just go on hospice and we never really hear. So we've been trying to be really good about notifying the
Correct.
provider once the patient has passed away and maybe like send a card. I know I like to do that a lot of the times if I hear a personal story about, thank you so much for trusting us with the care of your patient. They passed away peacefully on this day, surrounded by family. And I think it's just a nice touch to let providers know how things went.
And also in the interim as well,
Mhm.
a lot of providers want to be in the know, like during the hospice services. So our medical director will collaborate and send the messages out to our primary care physicians. They won't be involved directly in the care, but they'll be involved with the patient on a more personal level. And we're definitely willing to, of course, with patient discretion, meet with the primary care physicians and have doctor-to-doctor consults with the primary care physicians, just letting them know what the services we're providing, how the patients are doing on our services to that effect.
So when they get put on hospice, they typically start off with probably about 2 visits a week, depending on the patient's needs. And then as things progress and they start having a little bit of a decline, we start adding more visits. Sometimes it's daily towards the end. But yeah, we typically start in twice a week with one main case manager, and then they also get a medical social worker to help with any type of community resource that they may need and family support. We offer a chaplain that will come. I know we have a really sweet head chaplain now that goes and sings to some of our patients if they want.
With chaplains, it's not all about religion. It's more for that
Yes.
spiritual support. So we don't want to push any religion on anybody.
Yeah, and they have the right to refuse that service as well
Correct.
if they don't want to use it. But it is there. They get a nursing assistant to come and help with personal care needs a few times a week. If it's something that is needed, we can help get them a volunteer for just companionship and respite. All my volunteers are put through special training and they've all had background checks. So if anybody's ever interested in volunteering for hospice, please reach out to us. I'll give you my contact info at the end of this. But it's a very rewarding thing to do to visit somebody at the end of life and have a pleasure of meeting with them. We also have bereavement support. So it's for the loved one after the patient has passed away. We try to check up on them about 13 months after.
Correct.
Check in, call, invite them to grief groups that we have, and just provide some phone call support, sending them cards and just checking in with them to make sure that they're doing okay. Um, so we put support through therapists as needed. So that is something that we added. It's not a paid service, but I know sometimes when we want to get somebody on hospice, a lot of times they were on our home health service getting physical therapy, and they don't necessarily want all that to end. So we let the PTs continue for a few visits. It's not covered under the hospice benefit. That's something that Ancora will do, and it's a very temporary thing, but we will offer it as needed if they need help getting like proper techniques for safety transfers.
Education,
Mhm.
maintain. Correct.
Yeah. And then we have full circle aftercare, and I'll talk about that more later in the slide. It's an aftercare service that we provide to all of our patients. Is hospice expensive? So hospice is covered 100% under the Medicare benefit. If they are not of Medicare age and they don't have that, we do bill regular insurances. So Medicaid, VA, private insurance, and we do take self-pay. I think that's pretty rare.
Very
Yeah, there have been a couple case by case basis for pro bono, like charity care. We've done one last year where it was somebody, I think they were a victim of stolen identity, or it was just a really crazy story where they really had no Medicare, no ID. The patient had a dementia, so they had like no social security card that they had been lost. So we were able to help them, but that's a case by case basis. So with the hospice service, we are on call 24/7. So that being said, and you can help me with this,
correct.
we try to triage over the phone if a facility or if a family member needs something. And then if that's not enough, then we obviously go out.
Correct.
So
they have their main caregivers who they have their scheduled visits, and throughout, of course, because our offices are open from 8 to 5, we have our regular case managers who work from 8 to 5. If so, the need arises where a patient needs anything after hours, we have our on-call nurses to go out and see them. And yes, it involves triaging over the phone, a little bit of education, and if there are any symptoms that do arise, our nurses do go out and assess those symptoms. Of course, because our hospice services is symptom and comfort management. So any new symptom that arises, we should be there as soon as possible to make sure that our patient is at their most comfortable.
yeah, and that comes with a lot of education with not calling 911. So they are told several times throughout the whole hospice process and the length of stay that they're on to call us first no matter what. And if they later decide, you know what, my mom fell and I'm really scared, sometimes they do end up calling 911, and then they'll notify us that your patient's in the hospital and the nurse goes right over and they have the right to revoke at any
Correct.
time.
But we're not there to, it's not a finite situation. If at any point they feel like they want to revoke our services, they can. And we have that pretty often because of situations of set like falls or anything of that sort. So they would go to the hospital. We would revoke their services so they can use their benefit to go to the hospital and seek that curative treatment. And we can get them back on our services if they decide to when they come back home.
Yeah, and a lot of times, I would say 9 times out of 10, they fall, they go to the ER, and the provider says, there's nothing really that I can do for you. We're not going to operate on this. They send them home, and we end up putting them right back on hospice the next day. So, if they would call us first, that's great. That way we can kind of assess and try to say, why don't we just stay home or, give them their options. They get physician oversights with these visits. We meet every other week with our providers to talk about any kind of pain and symptom management and the patient's comfort. We do a ton of caregiver education, like we talked about, especially with our on-call service. That being said, with the 24-hour on-call, it is not to be confused with 24-hour care. So when we admit the patient, we have a great rule that we require them to have 24-hour caregiver. So we don't always like to admit people that live alone. I know that we have done it in the past, but we really, really want to make sure that we have a proper plan in place so this patient is being left by themselves.
Right.
And even if that requires our social workers to help get them placed or give them resources to find an assisted living, reach out to the care coordinators. I'm sure you guys have been a ton of help to us in the past with making sure that the patient has somewhere safe to go and they're not at home alone. Um, and I think that I will go to the next slide. Okay, so knowing the numbers, I've gone over this in our last meeting. Um, and these numbers were pulled from the National Hospice and Palliative Care Association. The Alaska numbers, I'm not fully convinced are accurate. I would like to probably run my own one day. But that's why I have Ruben here, so he can kind of help let us know what he thinks. So it says here that the Medicare hospice utilization, the national average is 49.10%. In Alaska, this Palliative Care Association says it's 30% for Alaska. I feel like that's really high. I do not think that Alaskans are utilizing the hospice benefit like they should. I think that, yeah. So our top three diagnoses, I was talking to Ruben about this before the meeting, and I think for Alaska, what were you saying?
Well, definitely, we have a lot of cardiovascular issues, circulatory issues, and Alzheimer's. Cancers, we do get a few for cancer, but we feel like oncologists do not typically send a lot of hospice referrals because not only the oncologists, but patients always want to wait to the very end on stopping treatment or searching for the next new treatment. And so they always opting to continue to treat. And so by the time hospice may be considered, a lot of the times it's already too late.
Yeah, so we notice that a lot. We'll get them on and we might get a referral. We try to get them on right away and they last about maybe a week, when we think, oh man, they really could have had this for the last year. So when we do education with providers, we always say, like, if you look at them and you know that they're not going to be here in 6 months, please definitely reach out to us. We do not need a referral to just give somebody an informational.
Correct.
So we love to do those. If it's by the phone, we'll go in person to their house or to the facility that they live at to talk to them and meet with their family, just so that they know all of their options. Hospice by gender. So our administrator talks really great about this. We feel like women are more susceptible to be put on hospice first just because they go to the doctor more. And so I don't know if you feel like that's true. I know.
I do. I mean, here in Alaska, the consensus is that people come here to get away from everything. So a lot of, especially the males, when they come to Alaska, they've been doing their own thing on their own forever. And now to ask for assistance is something that's really hard. You know how the saying goes that when you get older, you do what you want, you say what you want when you want, and so that's kind of like the community here. A lot of these patients have been doing for themselves forever, and to ask for some assistance is pretty hard.
So that makes
Which is why
sense.
males don't usually go to the hospital as often and get these diagnoses so late in the game where now they really need that extra help and they just like, no, I'll just go do everything by myself like I've always done.
Yes, or they live really far out of our service area. But we do pretty good, and we cover from the beginning of Willow all the way to Girdwood. Yeah, yeah. So our range is pretty high. Hospice by age, obviously 61% is 85 and older. Um, and that number drops as people get younger. I feel like they get younger and younger every day, just depending on, the cancer diagnosis or whatever it is that they. We do see them pretty frequent, but I would say most of them are probably 65 and above that we do get. Hospice by race. We talked about this last time a little bit. I think that people, North American Native people, they maybe don't have healthcare as accessible to them as other people in different areas of the world might. So this is kind of like I said, numbers that they pulled from the NHPCO of just hospice by race and what they were kind of finding.
It's also based on the education as well. I mean, hospice is still one of those things that are kind of taboo.
Mhm.
So, a lot of the things with hospice is once you hear hospice, you feel like, oh, I'm dying tomorrow. They don't really understand where hospice is more of a symptom comfort management and it's just not seeking that curative treatment anymore instead of just comfort managing. Um, and like in a lot of the areas here are remote. So they don't get a lot of the education on the services that we could provide. And for them being that remote, they don't have the services there for it neither. So when we get a lot of the Native Americans here, they're mostly because they're based from Alaska Native Hospital. We get those referrals. So they're mostly here city based for the most part. We do get some from outside, but not often.
So I think a lot of it is cultural differences as well. Like food is a huge one when we try to explain to people not to force feed their patients, they really think like they need to eat or that they're starving them. So, like I said, we do a ton of education, but the cultural differences can be very difficult. And we respect everybody's decision, but we're just there to support as much as we can. Signs indicating hospice, weight loss, decline in activities of daily living, decline in their functional status, a lot of frequent hospital visits. That is a huge indicator that somebody may be ready for hospice. If the patient is expressing that they no longer wish to go to the hospital, a lot of times we hear that, and families are like, no, they have to go, which I understand they want to take care of their loved one. But when they start verbalizing, like, I don't want to go anymore, I just want to stay home and be comfortable, that definitely is a huge indicator that they may be ready. Do you want to add anything to that? It, yeah.
Pretty much, yeah. It's a lot of it. Because of course, like besides hospice, the hospice death/death is pretty much taboo still. Um, and going everybody grieves a different way, and families don't want to let go of their loved ones, but a lot of the time their loved ones are just ready, and they're just ready.
Yeah. Sleeping more, eating less. And I would say the frequent hospitalizations are a huge indicator that they could be ready. Okay, so disease stages and planning. We encourage providers to share information related to hospice as patient progresses through their disease. So attached, I'm going to skip a couple slides. I put all of the terminal diagnosis on this slide. So if anybody wants to go back later and review, but there's a graphs and that goes more into detail about the patient's disease process and when they should be ready to start getting on hospice. So obviously the main ones, kidney failure, Ruben said was a really big one. And I know with dialysis, they typically want to seek that treatment and they pass away pretty quickly after they stop doing dialysis.
Yeah. Dialysis is, yeah, I mean, they get tired of going, they go 3, 4, 5 times a week and, they just don't feel good when they're not on dialysis. So a lot of the times they just tend to just want to give up. And typically, on average, anybody that stops dialysis, what I've seen in my career is that about an average of 10 days after stopping dialysis is what it looks like for those patients.
And we have other, Parkinson's disease. That's something where sometimes they show a very slow decline and they're still very eligible. And we've had people with Parkinson's on for probably 2 to 3 years. So it doesn't necessarily have to mean 6 months or less, and that's it. It's proven that people that get the hospice benefit tend to live longer just because they have more support. So I think that's a huge misconception. I've had somebody that's been on that was 100 years old, bedridden, and lived to be 103 on our service. So it's just pretty amazing what the frequent visits and the pain management and the symptom control help can do for them if they just get to stay home and kind of, be happy there and get all the support that they need. So these are the ones I'm going to skip. You can always go back and review these. Kidney failure, liver failure, end stages of COPD. If they're oxygen dependent, that'll typically qualify them for getting onto hospice. MS, coronary artery disease, Parkinson's we spoke about. So these are something really great that you could review. HIV disease, ALS. I've seen a few of those in Alaska already. Um, it's not a super common diagnosis, but we have had it on there. Heart failure is a big one.
Cardiovascular up here is pretty big.
Yes. So shortness of breath, swelling to the lower extremities, dementia. So, dementia is one that I feel like a lot of providers don't realize is a terminal diagnosis, depending on the stages that they're in. So, we educate a lot about dementia if the patient it can't form a whole sentence, if they've had significant weight loss, if they're requiring more assistance with their activities of daily living. Um, Please reach out to us and let us know so we can send a nurse out to do an assessment and see if they actually qualify. Sometimes we just need like the last few visits that you've had with the patient.
Supporting documentation, because under the CMS guidelines, we cannot admit anybody with the diagnosis of unspecified. So we need to kind of determine where that dementia came from, either be vascular or Alzheimer's. And then we have our criteria to meet for them to be on services. Because again, this is another one where patients can last a while with comfort symptom management. They can last, the consensus is you need to send us a qualifying terminal illness with 6 months or less, but it doesn't necessarily mean that it has to be in 6 months. They just need to show some decline, whether minimal or great within those 6 months to keep progressing on our hospice services.
Yeah, and it could be a very slow decline. Another misconception is, they get put on hospice and that's it. But that's not true. If they start doing better, they start gaining weight, their functional status, yeah, we cannot keep them on. So it's a good day when we get to graduate somebody because it's a celebration and we say there's no penalties or anything. We just say right now you're kind of at your baseline. You're not really qualifying, but there's no penalty to you for graduating off of hospice. And when you're ready for us, we'll be here when you're ready. So these are the chronic disease trajectory models. This is a video that didn't work the last time, so I'm hoping that when you put this on your YouTube channel that it will work for some people. It's just a little 5-minute video about a patient who had a terminal diagnosis. She had a wonderful outlook on life, and she went to the ER. Her oncologist did not refer her, and she was having some pain. And they said, Patty, you're hospice appropriate. You're terminal. Are you still going to chemo or radiation? And she said, no, but I haven't gone in months. And she said, I didn't think that I was ready for hospice. And so she talks about a whole story about how she advocated for herself and decided to tell her doctor that she wanted it. And she had another good 8 months on service with us. She got a very close relationship with her nurse who was visiting her very frequently and a volunteer, and they became fast friends. And it's just a really great story. Let's see if I can skip that. Oh, do you want? Should it work? Should we watch it? Okay, I'm gonna press play.
Good. Oh no, I don't think it's working, Maria.
Oh,
Oh,
Yeah.
sorry. Sorry. I'll try to skip to my next slide. Do I have to? Okay, so loss is hard. We're here to make it easier. I can't speak for any other hospice. I don't know if other hospices here in Alaska cover this service, but it is something great that we do for all of our patients. We pay for everybody to get this after their loved one has passed away. It's called Full Circle Aftercare. So after the patient passes away, the next day, the social worker will put in a request to reach out to the family member, the power of attorney, or whoever that may be, to help do have a meeting to go over through any type of end of life questions that the person has. So personal assistance with estate planning. um
Social
yeah.
Security, government issues.
Yep. And then at the end of the meeting, they'll send you an email. They'll send the family an email stating what they need to do and what was talked about that day. So it is awesome. It helped me a lot when I had a loved one on our service because I had a lot of questions that I didn't even think about. And so they kind of helped me navigate that. So I love Full Circle Aftercare. Um, so, when we have a patient on home health services like physical therapy or skilled nursing, if they graduate from that service and we help to reach their healthcare goals, we have a bridge program. It's awesome. It basically kind of helps us keep that patient on our radar. I think this started from one of our Arizona companies where a physical therapist was discharging a patient, and she was kind of sad and she felt bad, and the next day he went to go discharge her and she was actually on the ground in her house and he found her. So after that, they thought, like, what could we do? And so we have a bridge program, and it's basically, I would call it like a wellness check.
Mhm.
It keeps them on our
Very
radar.
basic.
Yeah, and we check on these people once a month. And so it's great when our bridge reps show up to their house. They've had established a good relationship with us, so they know who we are. And we just ask them questions like, how have you been doing? Have you fallen recently? When's the last time you went to the doctor?
Just making sure they don't fall through the cracks because a lot of
Exactly.
the time when they go on like home health services, once they get their services, they just kind of like disappear for a little bit because they feel a little better, they got their therapy, and then something might have happened and nobody's there to follow up.
Yeah, so the bridge program's awesome. We get a lot of people that end up coming onto hospice when our bridge rep shows up and they say, "Oh, I just got out of the hospital, and I just found out that I have this or something else." So we help get them the information that they need and possibly admit them onto hospice or get them put back on home health.
Did you have a slide you want to advance? We still see the lady.
Oh, you
Oh,
do?
Yeah.
Oh
it's not
no.
showing, huh?
It's working on my end. Shoot.
So it
Maybe.
says,
You have to reshare. You'll
yeah.
have to
Oh,
hit
I
the
do.
share again.
Okay.
Just go to the little share green box and pick the file.
Did it change?
Not yet.
Shoot. What about now?
Mm-mm.
That video gets me every time. Okay. 1 second.
There you go.
Okay. So this is the full circle that we spoke about. This is the aftercare service. It's like, oh my gosh, it hates me. Okay.
This was our bridge program.
Yep. So this is the bridge program that we spoke about where people come and check on them. Okay, here we are. So home health equals independence. So we'll talk a little bit about the home health services that we provide. Recover, educate, and restore is the motto for home health. So, for home health services, Medicare says that the patient has to be considered homebound. So, that doesn't necessarily mean they can't ever leave. It just has to be a taxing effort for them to leave the home. So it can't just be like, oh, I don't have a ride to therapy. I need home health. It needs to be a little bit more in depth. But as long as it's a taxing effort, or they really have, if they struggle getting into a vehicle at all, then that would qualify them for home health services. So with that, the home health team has skilled nursing. So we just need a referral from the provider. Skilled nursing, they have to have a skilled need. So if they have wounds, that would be a skilled need. If they had a Foley catheter, we could come in once a month to change that. If they needed a little bit of assistance with maybe a little bit of education with medication management, that those are very short visits, but that is something that we can help with. If they're a veteran and they need assistance with medication management, that is something that the VA will cover at 100%. So that is a thing that is just ongoing. So if you have any veterans that you know live alone, or that need help refilling their Medisets, definitely let us know. We'd be happy to come and help. Um, if they've had a recent surgery and they need physical therapy and they can't get to an outpatient therapist, then we could send a therapist to them a few times a week until we help them meet their healthcare goals. We have speech therapists that can come into the home, occupational therapists, medical social workers if they need any assistance with any type of resources, and then a certified nurse assistant to assist with um, bathing and any kind of personal care needs. So I kind of spoke about this already. Medication reviews for the hospice or for skilled nursing, disease management, symptom control, and wound care are the big ones for a nurse to be able to come in. So physical therapy, if they need help with mobility issues, help with reducing pain, preventative injuries. I know the physical therapists are great. They do a lot of education to help prevent falls because we all know that that's the number one killer in our seniors is falls. I don't want to do that. Occupational therapy, that is always something that we struggle with getting occupational therapists up there. We do have one, he's awesome, and he's kind of helping between Anchorage and Wasilla right now. So if you know anybody that needs occupational therapists, would be happy to have you send us the referral. Sometimes they're just about a week or two out to get them on the
That's
schedule.
one thing we've noticed here up here in Alaska. It's very short-handed. It's occupational therapists. We're definitely low on occupational therapists here in
Yeah.
Alaska.
Yes. And I think sometimes we have a sister company in Arizona and Utah. And once in a while during the summer, will ask, "Hey, do you got any therapists you want to send up?" And a lot of times I go, "Yeah, I want to go spend the summer in Alaska," but the wintertime is not so many volunteers for that, unfortunately.
I don't know why. What could it be?
Who knows, right? Um, we did have a therapist that could do swallow studies in the home. And she just recently went and left us for Australia. But the next one we get, we're going to help get certified to do those swallow studies in the home because that really, really helps if they're aspirating and if they can't make it out. But right now we just have the regular speech therapy evaluations. And so next, okay. I might be done a few minutes early so we can be open for questions. Ancora has sister companies. So we're under a healthcare umbrella called Aegis. And we have Atlas Medical. It's providers that we work closely with in our facilities that serve as primary care for patients that are in the bigger facilities. So we're in a lot of the ones out here in Anchorage. We're in even in most of some of the small ones too.
Mhm.
We're always looking for more patients. If providers have anybody that is homebound or you notice are missing a lot of their appointments and they live at a facility, be sure to let them know that we're there if they can't make it to their appointment. We send providers to do primary care in facilities about once a month. Um, and then we have Triton Supply. It's our DME company. So under the hospice benefit, all of their durable medical equipment is included in that. So upon admission, the patients can get a hospital bed, they can get a bedside commode, an over the bed table. Um, all of the incontinence supplies are included. So Triton's the person that the company that we use for that because they are our sister company. And then Pharmacy Partners is where we get all of our comfort medications from. So that one's located in Wasilla. And we have delivery drivers that bring out the meds to the Anchorage patients.
Daily. They come on every morning for daily routine medication management. And of course, if we have any issues where we need stat medications, we can provide those as well.
Yeah, and that's the great thing about having our own pharmacy is that we do not have to wait. So if somebody calls a family member, a facility, and they say, hey, they're in a lot of pain, we have morphine and it's just not working, our pharmacists are on call 24/7 and they will open the pharmacy and we can call the medical director and make sure that the nurse knows what to take out and we can get that medication to them same day. That is not always the case for other hospices. I know some of them here in town, they have to send them for them out of state. So that's just something that we are very happy that we could accommodate same day within hours. Does anybody have any questions for us? Let me see if I can go on to the
There's a
chat.
couple in the chat. Hmm.
Okay. Feel free to type questions in here.
So we
One
do
says,
not have services in Kenai as of yet. Um, I have proposed it because I am a prominent fisher. I wouldn't mind going out to the peninsula, but unfortunately, we do not have services at the Kenai as of yet. I know it's been talked about, but we'll see what happens in the near future.
Do
Yeah,
you
so
maybe know an agency that's in Kenai that provides kind of similar
You know
services that
what?
you
I think I've Googled something in the past. I know that area in Fairbanks is tough. And a lot of times these people are relocating.
Mm.
They're relocating to be put in our service area. We've had people come from Talkeetna. I think I talked about this in the last meeting that one of the hotels in the valley was very accommodating to us for a patient that was way outside of our service area and the family came and they were lovely. They moved their bed out. They let us put our hospital bed in and the nurse just seen them there. And thankfully they had the funds to make that happen. But we have that a lot, where people are just really far out. But we do go to, I believe it's mile 70 of the park. So that's the beginning of Willow, Palmer, Wasilla, the beginning of Sutton, and then of course Eagle River, then Chugach, yeah, Chugach, Anchorage. So we have a pretty big service area, and we probably do more, but we have that one on-call nurse that's on call for each location. So you could imagine that if somebody calls them, and they're in Sutton, and then somebody else needs you in Willow, it's quite the drive. So that's why we had to make our, if we ever had nurses that wanted to work and live in Talkeetna, we would open it up to them. I can put my information to see how to get in touch with Atlas. Right now, I am in a lot of the facilities out here, and I can maybe, Kat, maybe I can send you the list of facilities that I'm at, and you can share it with the group.
Yeah, we could share that.
Yeah, just reach out to us. I when I start a new facility, we like to have at least 4 patients on board at once. It's a lot for a provider to go into a facility for just one patient. So I'm happy to go and talk to facilities and let them know about the benefits of it. It's awesome. And our
And
providers out here are great.
there's a question in the chat on how to get in touch with Atlas, and then a follow-up question if a provider agency believes the recipient needs hospice, can they reach out to Ancora directly, or do they have to go through the provider, through their medical
Um,
provider?
So they can reach out to us directly and we can give them a basic informational, but we need a referral from the provider. And so sometimes they send a few things and we just say, hey, we're missing this, this, and this. And then whoever works at their clinic usually will send us the rest of the documentation that's required. Um,
And like Maria said earlier, it doesn't cost us anything to go on and have these conversations. So if you feel like a family would benefit from hospice, you could just reach out to us before sending anything, and we can have those informationals with them. And if they were to agree, then we can go through the processes of getting a
mhm.
referral, what's needed.
Yeah. And we try to do a lot of lunches. I notice more lately, though, that clinics aren't really doing lunches anymore. So it makes it harder for us to spread the word. But there are so many common misconceptions. And sometimes when I go to lunches, providers are like, well, I heard that it's really expensive. And one of my patients passed away, and the wife got a huge bill. And so I'm always happy to talk to them and make sure that they know that it's covered by Medicare at 100%, and people, tend to live way longer with the benefit.
For the most part, even with private insurances, once their deductibles and co-insurances have been met, it's most of the time pretty much covered under their insurances as well. It's very rare we have instances where patients have to pay out of pocket.
Yeah, and if anything, they save more money because they get all of their incontinence supplies that they were spending a lot of money on, medications that they don't have to pay for. So that's what we've noticed. Are there any more questions? Yeah, so we just need the PCP to send a referral, but like I said, we're happy to give anybody any kind of informational, talk to families so they can help advocate for their patients. And just let us know if you notice a huge decline and you notice that they're going to the hospital a lot, or they're just you go and visit them and you're not very clinical, but you can tell that they've lost weight by looking at them from the last time you've seen them. Just reach out to us and we're more than happy to call and send somebody out there to do an assessment. So I will add my phone number to the chat if anybody wants to reach out to us.
This is
Feel free.
Tara. One of the bigger questions we get with SDS is hospice duplicative of any waiver services? Like if somebody lives in a group home or gets residential supported living in an assisted living home with the waiver, can they still have hospice?
Of
As
course.
far as like the Medicaid waiver and stuff, yes, definitely.
Yeah, it doesn't affect anything.
It's not duplicative. Yeah. I've worked with a few people over the years who were at end of life and living in the assisted living home getting waiver services, and a few people who weren't at end of life but simply living with complex medical conditions, and they also qualified for hospice.
Hmm.
So it came and went in their life, like you described. But I think I agree, people don't know about the benefit a lot, especially for our people with complex medical conditions, just living with chronic conditions like that. Um, it would be helpful to explore. So maybe they and the family can get some of these benefits that you offer.
Yeah, and a lot of times what we're seeing is that they end up on home health. And so what we've tried to work on is making sure that the home health nurses know to look for the signs as well. And they kind of help us like, hey, this person's really declining. I really think that they're hospice appropriate. And then we can do the rest of the work from there.
And it, like you said earlier, it is pretty hard when you have people that have been independent all their life. And then to have these, so sometimes it may take more than just that one conversation, but we're willing to go to whatever level of help needed so we can get them to that headspace where they might think that this is for them.
I think that they hear the H word and it automatically means that they're dying and they're giving up. Sometimes I don't even say it. I say comfort care in the home. And that's a big one that really, really helps. And I don't even say the word hospice. And I say, well, if you would like to just stay home, and they go, yeah, I want to do that. I don't want to go to the hospital anymore. Um, I'm tired of going to radiation and I'm done with dialysis. I just want to stay home. And then we say, okay, well, let's try to make it happen. But we're in homes, we're in facilities. We have a GIP contract with Matsu Regional. So sometimes patients end up there, like I said, very last minute, and we will admit them onto hospice under the GIP um, criteria, which is pretty significant. You have to be having a lot of unmanaged pain.
Correct. So, hourly pain management, severe anxiety, something you can't really manage in the home, where sometimes IV medications are the best form of assistance to these patients.
Yeah, so we do. Do we do GIPs in Anchorage? We do, right?
We do with Alaska Region as well.
Yes.
That's great.
So yeah, do you guys have any more questions for us?
I remember as a former job, I worked, I supervised a lot of group homes, and some people were at end of life, like I said. And as the administrator of homes, I worried a lot about the medication and the different patterns of staff, people coming and going, and things like that. I just wanted people to be safe, and I felt that I experienced that their hospice care worker were so supportive. Even upon the event of their death, they came and took all the meds, and I did not have to worry. Nobody had to worry, it was super safe. So
We
I
are
would,
very, very up to educating. So I know that one of our nurses in Anchorage actually sat with the facility and some of their staff in different shifts and kind of went over the medication management because the state of Alaska has them on file to where it talks about how to administer morphine because that is one thing some facilities are not okay with. I have a couple in the valley that are just like, we don't want to administer morphine.
The same thing with hearing hospice. You hear morphine and it's like right away, absolute death, but that's not the case.
Yeah, we're just trying to keep them comfortable. And most of the time, we start them off on a very baby dose to just kind of help them relax. And it helps with their breathing.
Shortness of breath,
Mhm.
increased pain. So it's definitely medically indicated. It's not nothing where we're trying to help the patients progress into their end stages.
Huge misconception. Um, so yeah, we're happy to help educate too if they're struggling with administering that medication. We can kind of put them through a little bit of a course so they can get signed off, just so they have something on paper too. We've done it in a couple of the homes in Wasilla where they just really wanted to have it. And so we said yes, of course, because if not, then they'd be calling us, right? Which is fine too. But we will syringe them all up and pre-dose everything and help them make a schedule and show them how to do it.
And of course, we're available for,
Mhm.
at any time they have any questions. So they can
Yes.
call us before administering. If they think they need to administer, we can triage over the phone, or we can have the nurse go actually out there and see them.
And
So
sometimes in the beginning, they don't need their comfort pack at all. So when they get admitted, they get a little pack, and we just kind of keep it locked up in the closet at the facility, or we give people lock boxes to keep them
Yep.
just in case they need it for emergencies, you know. So I know I had a
Yeah.
family member that didn't use it until she really couldn't stand it anymore, and then we had to call and say, "Okay, it's here. How much do you want me to give her?" And the nurse was able to talk me through
mhm.
everything. Yeah.
That's great. Do you
Yeah.
include staff? I mean, in my experience, I had staff who were extremely dedicated, to the folks who were in passing at end of life. Do you also have staff participate in the grief piece? Like kind of like a family member who would? Would that be something,
Yeah,
a
we
thing?
like to send them cards a lot too if they're very, very involved. Because it's a huge loss, especially for the caregivers that are in the facilities. You know, they treat that person like their family, and they struggle too with like not feeding them anymore.
Mhm.
So we've gone into facilities to tell them like, hey, this is end of life education, and they actually get a more euphoric feeling when they don't eat. That actually helps them with their pain. Um, and we try to just educate on not force feeding. That's a huge one.
You gotta realize sometimes before they even come on our services, they've been living in these facilities for years before we even come in. So they have this family vibe already. So it's for them, it's like losing a loved one also, not just a patient. So
And we're outsiders coming into their space, you know, so it's an honor for them to let us into their home. And we're very cautious of that. Um, and just try to make sure that we just help teach and
Thank
keep
you.
the person comfortable. You're
you're
welcome.
very welcome.
Well, thank you so much. We appreciate it. And feel free to share this on your YouTube channel or anywhere that you might need it. I put my number on there. You can call me directly if you have any questions for Ancora and Atlas. I work for both. So,
Great.
Awesome. Thank you so much for
Yeah.
coming. And,
yeah,
presenting.
thank you
Once
so
again,
Pleasure.
for
much.
different folks here, but thanks so much for coming again and doing
Yeah,
this.
you're welcome. Reach out to us
It's
if
a
you need
pleasure.
anything.
As always, our sessions are put on our YouTube channel, and I did grab that video and put it on the YouTube channel, and we'll send a link out along with a, a PDF copy with just a smaller digital file of this presentation to all who attended. And you can share it, and we'll make it available upon request to anybody.
Awesome.
Yeah,
Thank you so
thank you.
much.
Thank you so much.
Have a great week.
You too.
Everyone.
Bye for now.